If you're not on Workplace, we're happy to get you on there, or we're also happy to share with you a link that you can watch or share the webinar information with. While our presenter is speaking, we will have the lines muted to reduce unnecessary noise, but we will unmute at the end of the presentation for questions and comments, and I encourage you to use the chat box throughout the presentation. We will be monitoring that. Today's session will describe the value of working with stakeholders to fight the opioid epidemic by expanding adoption of the CDC opioid guidelines and best practices. It will describe the stakeholders Mountain Pacific engaged and what activities and interventions were carried out to reduce opioid prescribing rates in Montana, Wyoming, Alaska, and Hawaii. We think it's a great example of a campaign that aligns with Choosing Wisely, and we'll include in the discussion some thought about how to promote Choosing Wisely through complementary campaigns such as opioid or antibiotic stewardship. We're super excited to welcome today Stevi Sy. She's a registered pharmacist from Wyoming with a doctorate in pharmacy awarded by the University of Wyoming. She joined the Mountain Pacific Quality Health Foundation team in January of 2017 as the Adverse Drug Event Prevention Task Lead for Wyoming, where she focuses on process improvement and development of medication safety programs. Her areas of professional interest include regulatory and policy affairs and appropriate stewardship of medications, including opioids and antibiotics. She's passionate about reducing provider burden and improving employee satisfaction in the healthcare environment. So I'm very excited to pass the baton over to Stevi and have her share her story with you.
Thank you for that introduction. I appreciate the invitation to come and talk with you all today and to share a little bit about the quality improvement work we have accomplished in our 4-state region. They have already gone over nicely the objectives that we are looking to go through today. Just to remind everybody, we are going to want to talk about the value of working with stakeholders. This will be from the Mountain Pacific perspective, where we are quality improvement consultants working with both patients and providers. And so we're going to talk about ways that we tie those two groups together along with some of these external stakeholders that also have a hand in improving the quality of care throughout the nation. So a little bit about Mountain Pacific Quality Health. We are a quality improvement organization, part of the Quality Improvement Network funded by the Centers for Medicare and Medicaid. We started in Montana back in 1973, and now we operate in mostly rural communities. So we work in Montana, Wyoming, Hawaii, and Alaska. We also serve Guam and American Samoa and Saipan. We hold a many federal, state, and commercial contracts to increase the quality of care, making sure that things are affordable, safe, and that they add value to patients. And that perspective has shifted to really focus more on that last piece where we're wanting to make sure we have good value to patients. They are a valuable member of the care team, and that is an area where we have a lot of opportunity for improvement, and we'll touch on that a little bit today. As Kelly mentioned, I am a pharmacist. When I came on board with Mountain Pacific Quality Health, one of the large tasks that we were just beginning to work on was improving opioid safety and safe opioid prescribing in our region. While we were building our program and assessing our need, we discovered some positives and negatives in sort of the baseline of that environment. So we'll go through and we'll talk a little bit about what we found. Looking at opioid prescribing in our areas, starting on the right-hand side here, you have 2014, and then as you move left, it becomes more current. 2017 is the most current data we have for opioid prescribing rates. When we started assessing, we had a nice mix of above national prescribing rates and below. There are a lot of things that play into that. The rurality of our states tends to increase the number of opioids given to patients because access to care concerns drive this perceived need that we should give them more doses of their pain medication post-surgery, post-injury, in order to prevent pain and suffering if they're not able to come in. And then also because we have a lot of blue-collar work, hard physical labor, and a lot of ranching communities in Montana and Wyoming, we found that those areas experience higher rates of opioid prescribing as well. Despite the fact that we do exceed the national prescribing averages in Wyoming and Montana, there is a culture in the healthcare community where we deny that opioids are a problem. There's not a perceived need to make changes. And so part of Mountain Pacific's task has been turning the tide with that healthcare perspective. Patients, surprisingly, have been much more in tune with being aware that there are issues, feeling like there's more of a need to make changes in this area. And so as we began this work, we like to collect data because everyone likes to see where they're at. It helps drive conversations and engage members and interests. And so one of the places we started was talking about the different cultures we have in our states and ways that we can learn lessons. For example, in Hawaii, we have a different culture around pain perception and the way that we should treat pain, and that results in lower rates of opioid prescribing. And so there were a lot of initial discussions about how we could expand that sort of attitude and learning into these other areas. At the same time, we wanted to really dig into what was happening with opioid adverse event rates. So an opioid adverse event is something that we pulled from claims, and we based it on either patient harm events, such as admission to an ED emergency department or an inpatient stay for respiratory suppression, respiratory failure, extreme confusion, sedation, or falls related to opioid use. Those are all things that we defined as an opioid adverse event. We also tried to roll in morbidity and mortality from opioids. So we were tracking opioid death rates along the same time period. And this slide does move the opposite direction of the previous slide, so I apologize for that. But you'll want to look at it from left to right. And you can see, as we gathered that initial baseline and really started working, we started targeted education with a lot of different stakeholders and groups, including some of our large organizations that cover our states, some of our major health systems, and then many of our rural independent practices. And we were able to change the perspective around opioids, along with a lot of other partners working on the same issue, and we started to impact that opioid adverse event rate. And Jennifer has asked, how does opioid use or prescribing differ on the reservations versus other areas of our states in our program? That's an excellent question. We do have several areas of reservation in all of our states, with many different tribes and groups represented. In Hawaii, the indigenous population is part of what lowers that opioid rate. They have a strong culture where that is not a predominant way that you would deal with pain. The Indian Health Services in Montana is a very different, in Alaska, is a pretty independent system, and their prescribing rates tend to be match the rates that we see in other counties. In Wyoming and Montana, Indian Health Services chooses to not dispense opioid medications on the reservation, and so those folks travel to receive opioid pain medication when they require them, which has its own set of complex issues. We do find that those patients, that particular population, is more high risk than our non-Indigenous populations, and that is something that we have worked hard with Indian Health Services on to develop more relationships, because we do recognize, particularly in Wyoming and Montana, that the opioid prescribing rates are higher. There are more indications of high-risk behavior like multiple providers, multiple pharmacies, and then high morphine milliequivalents. And so we're working with some of the tribal leaders to provide education for family members as well as providers in those communities. This is a picture. We use both Medicare and national data to help get an idea of what we're up against when we're looking at opioid prescribing rates in our areas. We're kind of all over the board in terms of opioid-related hospital utilization. So this is HCUP data, and it just reflects, this particular one is inpatient stays. We also now are reporting emergency department utilization for all of our states. That's part of our education and initiatives that we've worked with our hospital associations on. Because of our rurality, we weren't always collecting that data, so we didn't have a good picture of where we were at the beginning. It's hard to make improvements when we don't know where we're sitting, and so that's big progress that everyone is reporting now, and we're able to have a better handle on what is going on. And this is a graph where you can sort of see some of those perceived healthcare discrepancies, where in Wyoming we have a higher than average national opioid prescribing rate, but we are lower than the national average on opioid-related hospital utilization. And that drives some of that discourse about whether or not there is an issue. And so digging into why we're able to safely use more opioid prescriptions or assess whether or not that is just a reporting error has been a part of our programming. And we don't have good results to share on that yet. We suspect that it is an underreporting issue or a lack of patients reporting for care when they should, not that there's truly more safe behavior going on. But we haven't conclusively been able to determine that. And then we talk a lot about state-specific hospital utilization. There were some changes when we moved from ICD-9 to ICD-10, just in the reporting. We were able to capture more of that information. So we were probably underreporting now, and we're getting a better accurate picture because of the increased specificity with ICD-10 reporting. There are some protective factors that we have in our 4 states that do reduce opioid overdose deaths and opioid overdose in general. Some of those factors include active engagement from our healthcare academic community. More and more of our schools of pharmacy, colleges of nursing, our dental education programs, and we don't have a ton of medical schools here, but those organizations that are active in our states have been very involved in educating our healthcare population to talk about the risks of opioid prescribing and the change in our knowledge and communicating the updated practice standards, because that is a big shift, especially for those of us that have been practicing longer than a decade or so. We've moved people through the 80s where we really didn't use opioids at all, and then we had all this information about pain is the 5th vital sign. You're not ethically treating patients if you're not controlling their pain. This big push to treat all pain. And now the pendulum is swinging again, where we know this screening of pain and all of these opioids are really causing patient harm. The academic community has been very engaged in our area to jump on board and help promote some of those changes so that we can adopt a little bit quicker. We have a very collaborative, bi-directional communication with our professional licensing organizations. because our states are small and there are small numbers of providers, we have better access to boards of pharmacy, boards of medicine, boards of nursing, and when there are issues that come up in certain areas, it is easier to quickly communicate with those groups to address those areas of concern. I think that if you happen to have the ear of your licensing associations, that has been very key in giving providers the support they need to make practice changes and to help educate their peers as well. We don't always want people to carry a big stick when we are making changes to practice standards, but quite often those licensing organizations do have a charge of protecting public safety, and so their missions align nicely with the need to address concerning behaviors and assess for patient risk. We have a large group of professional organization networks that really incorporate just a very small community of people, and so it's easier in some of these rural areas to reach out to, like for example, I'm on a state task force for opioids where we have a representative from the governor's health task force, the hospital association is there, Mountain Pacific gets to attend, Medicaid is there, and these are all people that are in positions where they can make changes and impact policy. And that is a nice protective environmental factor that I don't always feel like is as possible in larger communities where there might be more pressing concerns for some of those high-level individuals. And then we had a clear communication of a sense of urgency. I worked for many years as a retail pharmacist in ambulatory care, and when there were things that were concerning, say you got prescriptions where something didn't feel right, you're in an environment where it's easy to alert your other care providers in that area because you're well connected and you know each other. And there is a strong sense of community in these rural environments because more often than not, those patients you're caring for are also your neighbors, and their impact on the community is a little bit more evident, and that sense of neighborliness helps provide a little bit more protection and create that sense of urgency to really take these risks seriously and know that there is an individual level of harm that can occur. So those are things that really helped in our states, and we tried hard to build off of those things and not diminish them or reduce their level of importance, because there is this perception in our community that perhaps our opioid risk is not as severe as other areas of the nation. And these things are part of why people feel confident that we don't have an issue, and we work hard to change that conversation from, yes, we have these protective factors, but we also have these concerns. So when we started our work, this was a 3-year snapshot that we are looking back on, and we really worked hard to look back on who our key stakeholders were in the work that we could engage. And I feel like this can happen at any level of grassroots. It can be, like a state organization like the Hospital Association or like the QUIO where we cover a region. Anyone can initiate these conversations. In Montana and Wyoming, for example, opioid safety really began as a grassroots effort from our pharmacists working at the Medicaid offices on drug utilization reviews, because they were able to see the harm that was occurring when patients received high opioid medications and then were hospitalized. They could see that loop. And so they really began the grassroots efforts in those 2 states to engage stakeholders. And the way that we have assisted them is to expand those efforts. So when we're looking for stakeholders in any sort of quality improvement work, there's sort of a stepwise approach that you can take. When we're trying to identify our key stakeholders, you need to first look for who has a shared responsibility. More often than not, like our current program director talks a lot about how the government is not very creative when they have a focus on one issue. They expand that focus across many different contracts and organizations, and they ask a lot of people to pitch in. So with something like opioids, there is a lot of shared responsibility to improve safety, decrease risk, and reduce the number of opioids that are going out to patients unnecessarily. It's important to look at what is driving that need for change. In this case, it's unfortunately people are dying. We are causing death and despair and harming families and communities. So that is our need for change here. Not every quality improvement initiative will have that same need, but that's something that's important to know. And then we look to identify our individuals, groups, and organizations that can impact that issue. And we like to focus on partners that have similar interests. Either their funding requirements overlap, or they have aligned priorities, or they have a government directive. For example, we worked with some of our legislative opioid task forces in our states to help increase engagement and public education, and also expand awareness around policy, because that's been an important part of improving opioid safety. And then we really work on reducing duplication and increase collaboration. This is important both for grant funding, because we need to make sure those dollars stretch farther, but also it helps with provider burden. We ask providers to work on a tremendous number of quality initiatives, and making sure that they know where there is alignment and that something is additional support rather than another request and requirement for them helps cut down on the red tape and the burden to providers, and enables them to be better participants. The less reporting requirements you can tag on to someone, the more willing they are to say yes. Everyone knows these things are the right thing to do. It's our job as sort of the higher level stakeholders to work hard to remove barriers. So sharing some of our key successes, one of the first partnerships we developed at Mountain Pacific was just promoting take-back events. As I mentioned, we have very high prescribing rates still in Wyoming, Montana, and Alaska. Hawaii is very low, but we have a lot of unneeded and unused medications floating around in our communities. And so we partnered with our take-back events. Over the course of the last 9 years, we've collected over 145,000 pounds of unused medications. In Alaska and Hawaii, you can see some of our examples on the screen where we partner specifically with lots of groups to help really promote and push participation at a patient level to destroy those medications. And then in Wyoming, we've had a successful partnership. The Wyoming Medication Donation Program has successfully put medication disposal drop boxes in every one of our counties. So we now have total state coverage where 365 days out of the year, patients are able to successfully dispose of their medications. In the chat, you will notice that there are some Choosing Wisely tools that help promote the risk of opioids and create awareness in your practices. Please take a look at those. And with our stakeholder events, we worked hard to identify unique stakeholders in each area. In Alaska and Hawaii, partnering with healthcare providers was very key. That included pharmacies, some of our federally qualified healthcare centers, and also some independent providers were participating in on-site collection. We also were able to build partnerships with the Drug Enforcement Agency task force leaders in Hawaii. They participated in some of our community coalition, providing education to all different levels of healthcare providers, nursing homes, pharmacies, primary care providers, specialists, hospitals, many different levels, talking about the federal concerns and how those things correlate to why we have extra medication, why that's dangerous, those sorts of things. I'd mentioned the Wyoming Medication Donation Program, where we increased Dropbox locations. And then we really worked hard the last 2 years on beneficiary engagement. So those are our patients. We've utilized social media increasingly. More and more of our Medicare population is active on Facebook. So we've been reaching out to them via Facebook. We have a TV show that airs in 2 of our states where we've talked about medication disposal there. And then we do newspaper ads and flyers at key locations across the community to help emphasize cleaning out of your cupboards to reduce that risk of adverse event. So we also partnered with our hospital associations and the Hospital Improvement and Innovation Network. We worked hard to build this collaborative effort to reduce provider burden through shared calls and joint learning events, and then visible support to remind people, even though you're contacted by several different stakeholders, we're all asking you to participate in the same program. We really focused here on reducing unnecessary care, which I think is a nice alignment between the QuinnQIO program and Choosing Wisely. We wanted to improve patient education so that we could talk about whether or not you need an opioid medication, whether an alternative to opioids might be appropriate. And then at the same time, we provided education targeted specifically to primary care providers, surgeons, and emergency department providers, where we wanted to, again, talk about appropriate number of days supply. This is where our CDC guidelines really aligned nicely. We use that as the backbone for all of these trainings and educations and tried to really support it with evidence-based medicine and recommendations from various professional organizations. If you get on the Choosing Wisely website, they have a lot of those recommendations and the evidence-based best practices right on there in their tools and resources. I would encourage you to go check those out, find ways to use them in your practice or your work, because getting people on board with these CDC guidelines where we're reducing the total number of morphine milliequivalents, which is just that baseline assessment where we're correlating what is a tramadol dose equivalent to a morphine dose, equivalent to hydrocodone. It sets the bar equal for all of those things, so we really can drill into, at a clinical level, what is the patient's risk of harm, whether that is sedation, loss of function, respiratory suppression, and eventual overdose. The guidelines, there have been some unintended consequences there, but for the most part, when you're looking at treating acute pain, there's some very good hard and fast information on there about reducing the total number of days you're supplying. We've seen an uptick in providers reducing the total oxycodone tablets they prescribe and increasing alternatives to opioids, whether that be Tylenol, or we're seeing more pains designed to treat nerve pain, either gabapentin or pregabalin, Lyrica, looking at multimodal pain management to reduce the opioid need in the postoperative period has directly impacted that reduction in adverse events that we're seeing. We've also partnered with the hospital associations to expand training for the Colorado Alternatives to Opioids project in our region. The Colorado Hospital Association was generous enough to come to southern Montana and provide training to 17 different organizations about ways that they have expanded alternatives to opioids in their emergency departments. And in some hospitals, they have almost completely reduced the number of opioids they're using to zero, because primarily they're not needed in that acute environment, and they're finding people are getting better relief through other medications. And we know a huge percentage of people who go on to misuse or abuse opioids are given them in an acute situation. So if we can stop that initial prescription and that initial exposure, that reduces misuse and abuse and eventual illicit drug utilization. So working with providers to just stop that access and then providing more education for patients so that they understand the risks associated with opioids so they can make an informed decision about whether or not they want opioid pain management has been very successful in that environment. As I mentioned before, when I talked about Mountain Pacific, we work across many different contracts. And so we get to touch on opioid safety in a lot of different areas. We're involved in different Project Echoes, where we utilize that hub and spoke model, where you can share best practices and learning and case studies. So we participate in Behavioral Health Echo in 2 states that help promote better pain management with lower opioid utilization. We've provided some cross-task education in the merit-based incentive program, where we're working with Medicare to improve quality of the care delivered to Medicare beneficiaries, and through the quality payment program, where we're helping rural or underserved clinics meet those same base requirements, where we educate on just low-hanging fruit, things like how to access your state prescription drug monitoring program, how to use that as a clinical tool so that you can be evidence-based and have good conversations with patients about risk. We found that particularly with the prescription drug monitoring program, we needed to sprinkle that education throughout all of these programs, because as a clinician, you do not receive good quality education on how to use the PDMP in every environment. And once you do know what the risk is for the patient, there also wasn't a lot of education and discussion around how you have those critical conversations with patients at the next step, because for a long time, particularly in pharmacy, when we encountered that you had an area of concern in the prescription drug monitoring program, say you had multiple prescriptions from multiple providers, or you had many new early refills, you'd receive too many doses for your day supply, those sorts of red flags, we would refuse to fill. And turns out denying patients care can cause harm. Who would have thought? And so we've had to shift that conversation, where we talk more about specific recommendations based on the patient's risk, to where we pull them into care in that moment. Patients don't always understand the risk. It's a good opportunity to talk to them about their overall health and to involve their care team in what should be a big wraparound moment in care. When we identify red flags for a patient in their opioid use history, that is a time to suck them in closer, start the referral process for treatment, talk to them about medication-assisted treatment. Knowing who the providers are in your area for that can be very helpful. You can plug them into a Narcotics Anonymous group at that point. But we looked for all of these areas to talk about ways not only to share best practices for the CDC guidelines and PDMP use, but then also the next layer that we've added on is how do we not lose those patients to care then, because illicit medications are very accessible across the United States. And if you give patients no options at all, you increase their risk that then they will start exploring heroin or fentanyl, things that we know can be very dangerous and increase mortality rates. So that's an important lesson that we learned. So as we're partnering across those many contracts, we're looking for increased internal awareness as well. This is something that I feel like hospitals have mirrored very well also, where we look for better alignment. Do you have multiple groups in your organization that are working on the same initiative? Perhaps opioid safety is important for your quality improvement and risk people inpatient. We worry about it on the med-surg floors, in the ED, and then if you happen to be a primary care provider or specialty affiliated with the hospital, we've encouraged expansion of those education pieces and protocols to all areas of the hospital or healthcare system so that we can have consistent messaging, fewer asks of our healthcare partners, and then we really like to focus on partner goals. Through our experience, as we've learned more as quality improvement consultants about shared decision-making with patients, we've translated that learning into shared decision-making with some of our healthcare partners so that we are really aware of what the goals are for every organization that we work with, because not everyone's priorities are the same for lots of different reasons. And then we've just tried hard to work with our other partners like the Department of Health, our opioid task forces, the governor's offices, to have consistent tools, resources, and messaging. Again, this is where utilizing the CDC guidelines has really helped because those are very accessible across the entire nation. It's something that I think most of our specialty organizations are able to get behind, sometimes with modifications for their specific patient populations. And most of the tools and resources that you'll find on the Choosing Wisely website also have that as their backbone because there is good evidence that support that. So when we dug into our learning at the end of our contract period, after our 5-year cycle was over, we worked on opioid safety for 3 years of that 5-year period. We were able to identify some key characteristics of success. One of those characteristics was we were more successful when we had quality project management, which just means that we had some good defined project milestones where we were time-bound, we knew who was responsible for what, and we had a key contact person. If you're looking to do QI in your organization, I would say those are the first things you really need. You need to know the who, the what, and the when, and those have to be really fleshed out, and you have to know when you're going to revisit those so that you can assess your progress. And then we found that the team was very important. Identifying those key stakeholders for our across the region quality improvements and having subject matter experts was very helpful. Not everyone in every organization can be expected to be the expert in all things. So knowing who your point person could be, either in your organization or outside of it, can be very key to being successful. You'll want to consider your desired outcome, your service environment, and the impact on your population. So this is where when we were working on our reservations, our team needed to change, and we had to look better at the dynamics of who had skin in the game and was willing to come to the table and participate. A key part of this team in a lot of environments also involves having a physician stakeholder or a physician champion. That is very key to quality improvement initiatives in a hospital setting or in a provider's office. For a lot of good reasons, it helps to have a physician that can speak with other physicians, that can talk about peer-to-peer learning, and that can reflect back to you what the medical team's concerns are as far as patient care. And then whenever possible, you'll want a multidisciplinary team as well. We found particularly with opioids, because it is such a culture shift, it's helpful to know what reception's concerns might be because they're fielding phone calls from potentially angry patients. That nursing has a good say because they're doing a lot of the education at the end of a visit or at discharge, so that everyone can have a voice and also give you feedback on how things are going, because to be successful in quality improvement, you need to know when to adjust. Not everything is going to work 100% of the time in every environment, and so knowing what barriers you're encountering at different stages of the process is very critical. And then we found having a joint communication strategy when we're talking to patients or providers is very important. Everyone likes to get the same thing from multiple, they like consistency, It's very confusing if you're getting slightly different messaging from multiple different sources. It feels like everyone has their own agenda then. And when we initially got started, this was a piece that we were lacking. And once we were able to clear up that joint communication strategy, it really improved our ability to engage different stakeholders because they didn't feel like it was such a burden at that point. So when you're looking at your choosing wisely tools and resources, as an outside individual looking at what choosing wisely is doing, there are great tools and resources for patient education on there. Shared decision-making in pain management is a new idea. We should have been doing better informed consent with patients this entire time, but we have not given good information to patients about the risks of opioids, alternative options, what they can reasonably expect. We found in a lot of areas that patients expect opioids to bring their pain to a 1. That's not always possible in every situation. And so letting people know what they can reasonably expect and what our goals are in terms of function versus, quality of life concerns, there's more need for those conversations. So there are tools and resources on there to talk to people about alternatives to opioids, options for chronic pain management, post-surgery options. And then just remember that empowering patients to improve their care and quality of life is very, very key. We're finding in all disease states, the patients are often left out of the care team or their caregiver is, and that absolutely impacts patient outcomes. So take a look at those things. And there are additional resources as well. I referenced the CDC guidelines for prescribing opioids. There are chronic pain guidelines in there. There are also more and more acute pain recommendations. There are state-specific tools and resources. Lots of information for drug overdose prevention and patient education pieces. I also like to point people to the Federation of State Boards of Medicine. They have a model policy for the use of opioid analgesics in the treatment of chronic pain. This has a really great overview of what really good informed consent looks like for patients, where we really just provide good opportunity for a patient to address their concerns, develop realistic expectations, and talk about what the patient's goal for treatment is. More often than not, patients' goals are not, I want to reduce my inflammatory markers, or, you know, if you set the bar well, their goal is not, I want to be pain-free. It's things like, I want to be able to walk to the mailbox and get the mail. I want to safely navigate to my car. I want to attend my grandson's graduation. And we need to be cognizant of those patient-driven goals. And the Federation of State Board of Medicine, like I said, has very good tools and resources in there to talk about patient consent so that you can clearly outline the risks and benefits. The National Association Board of Pharmacy has prescription monitoring program information, including Interconnect, which is the program that allows you to check PDMPs across state lines. They also have the Safe Pharmacy Initiative, which helps educate patients about safe medication use, including drug disposal, drug abuse prevention, and then it also talks about online purchasing of medications, which we won't get into today, but that is something where patients, again, are not always aware of risks, so something to look at. And then I included the Colorado ALTO project. It is primarily for emergency departments right now, but it provides some good education about what alternative to opioids there are out there and can spark some different practice changes, both in the hospital and outside of it. With that, Kelly, I will go ahead and turn it back to you.
Thanks so much. Great and informational, and I think that we're also going to make sure that Lisa Letourneau is available to speak. And I think if we have questions from the audience, you were terrific at answering the ones that came into the chat. But if you have questions right now, you can unmute yourself by just clicking the red microphone and asking those questions or entering them into the chat box. But I guess I will start with a question of my own and ask a little bit about, you had, great information about which stakeholders to involve and the importance of them. Can you give some maybe introductory tips for people who have not started to make those relationships and how to outreach to them? You used existing networks that happened, but if there's people that you need to involve that you didn't think you needed to involve, were you cold calling them? Were you using other networks to get to those people? Maybe just for the people who have not used maybe a sophisticated network like you have, how to get started with that?
Absolutely. That's a great question. There was definitely a lot of cold calling that happened at the beginning of this. For example, in 3 of our states, we weren't involved in the opioid task forces, and so we did a Google search, and then we reached out via phone and email to say, hi, this is who we are, and this is what we're doing, and this is how we heard about your organization. Can we be involved? And I found that people are very receptive and have been very welcoming. We also have worked hard to utilize professional organizations to leverage new relationships. So asking, like I'm a pharmacist, so asking the Pharmacy Association to help me meet the Medical Association Executive Director, asking for some of those electronic introductions, usually just via email, to start those conversations has been very helpful. There are definitely people in some of those networks where if they know the name on the email, that helps you get started. And so if you're able to work with a hospital association or a professional organization to help make those initial connections, that is very helpful. Another strategy we used was to go to some of the different learning events, so whether that is a large conference or like we had some regional adverse event HIN work that was done, and we just tried to send representatives when we noticed those things going on. So watching the different listservs and things for those opportunities was a big part of building our network as well.
Awesome. All great strategies. We have another question in the chat box from Bill Adams, who says, it seems as if you're using informed consent and shared decision-making in the same way. Do you see any difference to the two?
I do tend to use them interchangeably, but yes, I would say there are differences. Informed consent, I think, is typically a really defined process that involves some paperwork where you want to document that you talk to patients about the risk. I think informed consent tends to be a more legal conversation where we make sure that we're clearly outlining for patients the risks and benefits of a specific intervention or procedure. And then shared decision-making, I think, is a less formal conversation. It's something that should occur more frequently. We can do shared decision-making for a lot of different things. I think any chronic or acute condition should involve some shared decision-making where you're just talking to patients about what they want from their treatment, and then what your ability as a healthcare provider to meet that expectation might be, and then working together to find something that can work for both of you. I find shared decision-making is super important with diabetic patients who may or may not be willing to move on to insulin or don't want to take their maintenance medications. That's a place where we use shared decision-making a lot at my practice site. But yes, they are different, but the goals of educating the patient are similar.
Great. Other questions from the audience? And unmute yourself and ask aloud, or also, again, happy to take it in the chat box. Well, I'll ask one more question. You were making some amazing progress in working in 4 states. Is there anything you're, I guess, consistently doing in any of or encouraging in the health systems to systematize this de-implementation? So I know you're using the guidelines, but in helping clinicians really making the guidelines easier for them to do? Are there any QI techniques that you're kind of using across the board?
Yes, we are really trying to encourage adoption of protocols in the electronic health record. So identifying a critical needs diagnosis like lower back pain is a good place to start, so that when you are treating for that, you can make sure you're talking to patients, having some hard stops in there to look at what is the patient's risk if we were to provide opioids. We like to embed some of those questionnaires for opioid risk assessment, so that if you prescribe a new acute opioid, there's a hard stop in your system where you then go through just a brief questionnaire to assess the patient's risk, so you can talk to them about misuse, abuse, the morphine milligram equivalent you're giving them, whether or not they might need the Narcan on hand at home. Yes, we like to automatize and put in the electronic record all of those things. And then for in the hospital system, we've really encouraged, as part of the EMAR, to flag, to assess patients for opioid overdose risk. So what is their respiratory rate? What is their level of sedation? So that before they can give the next dose of pain medicine, we're making sure that the patient is not already having loss of function and at risk for an adverse event.
Terrific. One last call for questions. I know we're pretty close to the end of the hour, but we probably could take. one
Yeah,
more
it looks
question?
like Bill has a question. Yeah, and is there training for providers on how to have conversations with patients about the issues? Yes, there are more and more trainings. Some of the trainings available from, oh goodness, when you do the CARE waiver, or when you're working on getting, special licensing to prescribe medication-assisted treatment, there's definite conversations there about induction, risk, and more you can find online education about how to have that training. I will look for some different trainings, and I will send those to you, Kelly, so you can send them out to your audience.
That would be awesome. It does look like we have maybe one more question before you end. Have you seen any work with employers addressing this in the workplace? At Gallagher, we have created some resources to address the stigma, and she's curious what you're seeing in the employer space.
Yeah. So my experience is pretty pharmacy-driven, but I am noticing more of the large chains are having pain management training for all of their staff, where they're addressing stigma, talking about those conversations when a patient is at risk, and then also what your professional responsibility is to reduce patient risk and to have more structured guidelines in terms of opioid utilization. Walmart is one that comes up a lot because they've got new policies in place for their opioid stewardship that have resulted in a lot of phone calls. They have the 7-day limit, no more than 50 morphine milliequivalents for the first initial fill. There's definite education there. I think we have a long way to go, though, in terms of across-the-board education, particularly for stigma, because we are losing patients to care because of the way we're responding to some of these patients that have red flags. So that's an area where I see hopefully things will improve over the next couple of years.
Yeah, no, that's a tough one, especially with how you talked about how the culture of treating pain has changed over the years. So that's definitely hard to communicate to patients.
Yes, and very drastically, and patients really feel stigmatized, and they feel like they're being called a drug addict, and we need to be able to better coach those conversations around risk assessment and being a little more compassionate, because we are losing patients to care, and that impacts our ability to help them live a better, healthier life.
Yeah, definitely an area we need to work on. Well, we're at 5 o'clock. Your presentation was so interesting. Thank you so much for coming on today. And thank you, everybody who joined us. We will be sharing this on Workplace, and I know several of you have also contacted Kate, and we're happy to email out the recording, and we'll also share the trainings that Stevi has very graciously offered to share with us. Next month, we'll be skipping our monthly webinar in December, but please join us in January 21st for our webinar on high-value care culture survey with Dr. Rashma Gupta from USC Davis. So thank you again, Stevi. Thank you, everybody who showed up today, and we will talk to you all soon. Thanks so much.